first Country Heart Attack Prevention Public Seminar. Thank you very much for being here tonight. I hope everyone is doing okay in these challenging times and staying safe at home. So just before we get started, I just want to let everyone know that we are recording this session to put on our website. So bear that in mind if you don't want to turn your camera on So my name is Steph Champion and I'll be hosting tonight's session. I'm an NHMRC postgraduate researcher with the Country Heart Attack Prevention Project, or CHAP as we call it, and I'm the coordinator of the CHAP education program. So this session is the first of two public seminars that we'll be hosting this year. The second seminar will hopefully be a combined in-person and online affair, COVID pending, with a pharmacologist as our guest. So just to kick off this session though, I want to first introduce you quickly to the CHAP project and the aims of the seminar, and then to our guest before moving on to our Q&A segment. So the aim of the CHAP project is to investigate strategies to increase access to cardiac rehabilitation for rural and remote patients. So despite the high level of evidence supporting the effectiveness of cardiac rehabilitation to help cardiac patients recover, many patients never start a rehab program. We want this session to be interesting and informative for you, so we welcome your questions throughout the session. So I've put together a list of interesting questions for Phil that are drawn from cardiac patients' experiences, but we'd love to hear your questions too. So please feel free to raise your electronic hand. Has everybody dealt with Zoom before and knows how to find the hands up button? And you can also put a message in the messenger and I'll be happy to read it out to Phil for you. So now on to our guest. Our speaker tonight is Dr. Philip Tedeman, and he is the Clinical Director of the Integrated Cardiovascular Clinical Network in South Australia, or ICCNet, and is a Chief Investigator on the CHAP project. Philip trained with the Royal Hobart and Royal Adelaide Hospital and the Flinders Medical Centre, and over the last 13 years has built an extensive clinical cardiology practice in regional South Australia and has been researching in fields of population health and cardiovascular health services at Flinders University. Phil has a keen clinical interest in rural cardiology and has a major role in developing, implementing and evaluating the role of cardiovascular clinical networks in South Australia, with the goal of ensuring that people living in country areas have the same level of access to cardiovascular care and equivalent clinical outcomes as people living in the city. So to this end, his areas of research have brought him to investigate strategies for improving clinical practice for cardiac care. So welcome, Phil. Thank you so much for being here tonight. Are you ready for the interrogation?
Thanks very much, Stephanie, for sure.
Fantastic. So I'll kick us off, but please remember that you can jump in at any time with your own questions as well. So because we're looking at this from the perspective of patients, that's the perspective that the questions are coming from. So my first question is, I was told that my heart muscle had some damage after my heart attack. Will this ever recover? And is it necessary to get this checked regularly?
Yeah, it's a good question. So most people who have heart attack will have some damage to the heart muscle. That's what a heart attack is. And it very much depends on the extent of damage at the time and also the timing from onset of the heart attack to when definitive treatment was able to be given, either to unblock the affected coronary artery, to restore blood flow to the heart muscle through clot-busting drugs, or through what we call primary angioplasty. That's the balloon technique to reopen the arteries. So that time from onset of symptoms to what we call reperfusion is a critical determinant of how much damage is done to the heart. So that some patients who present very early and we're able to reopen the affected coronary artery very quickly, within an hour or two, may not suffer any damage at all. That's for a full-blown heart attack. There's lots of patients who have very small heart attacks without a complete occlusion of a coronary artery, but with some minor damage to the heart muscle cells. And some of those people may not effectively have any obvious damage to the heart. But probably the majority of patients will have some degree of damage. And yes, that does, once we've treated the patient and reopened the artery, and if necessary, done what we call revascularization, that means to put a stent in the coronary artery or to arrange bypass surgery to stabilize the situation for the long term, then often that damage recovers. Now, whether it covers completely or not depends on a whole lot of factors. Certainly a number of the medications that we prescribe in hospital at the time of the heart attack are designed to limit the damage and to try and assist the heart in recovering as much as possible. And most of that recovery would be seen in the first 3 to 6 months after a heart attack. And we usually look at that by doing an echocardiogram, an ultrasound test on the heart. And you would have normally had a heart attack, an ultrasound or an echocardiogram at the time of the heart attack. If we do a repeat study in 3 to 6 months, we can see whether there's been any improvement. Is it necessary to get that checked periodically? Again, it depends on the degree of problem, the medications, other medical conditions like diabetes and high blood pressure as well. But most patients do need long-term follow-up, and it depends on the circumstances whether that long-term follow-up is with your GP or whether it's with a specialist, or probably most likely a combination of the two.
So that 3 to 6 months, is that how long a patient might expect to be seeing their cardiologist after a heart attack?
Probably a bit longer than that. The determinant for that depends a little bit on what treatment was given in hospital. So if you ended up having a balloon and stent procedure, the problem with that, particularly with the modern stents that we use, which we call drug-eluting stents, is that you can get restenosis or narrowing within the stent in the first 6 to 12 months. And so we tend to follow patients up for a minimum of 12 months in that circumstance. If a patient's had bypass surgery, you might only need to be followed up for 6 months and then back to GP, depending again on the circumstances. But most patients will require ongoing follow-up from their heart attack point of view with either their GP and not infrequently with their specialist as well.
So it's more, there's a group of people that you would be talking to, not just a cardiologist.
Well, yes, and particularly when we talk about cardiac rehab, which is the process from moving from acute heart attack through the recovery phase and into what we call secondary prevention. That's the phase where we are giving medications to limit the chance of you having a repeat event. Yeah, there would be a whole host of people, particularly in cardiac rehab, which we'll probably talk about sometime during this evening as to who's involved in that. But it's a multidisciplinary team that provide cardiac rehab these days.
Mm-hmm. So I couldn't rely on a stent lasting forever. Would it have to be redone at some point?
The general rule of thumb is if you get through the first 12 months without any problems, you're pretty unlikely to have any problems in that particular area of the coronary arteries. Very rarely we get late restenosis or narrowing in the stent. I've seen it happen out to 4 years, but that's pretty rare. Most of it would happen in the first 12 months. So if you get through the first 12 months and then later on you have a problem, it's usually a problem in a different area of the coronary arteries.
Now, this one was a question that came up from a patient online. I heard some clicking noises coming from my chest in the first few days after surgery. Is that normal?
Pretty much, yeah. So when you've had bypass surgery, they have to essentially cut through the sternum, the bony sternum in the center of your chest. And at the end of the procedure, that sternum has to be restabilized or fastened, if you like. And we generally use some stainless steel wires to tie the sternum back together, if you like. And that process obviously takes a while to heal. It's like a broken bone. Well, it is a broken bone. and that can take a minimum of 6, and we generally recommend 12 weeks of healing. And during that time, it's very important to allow that healing to occur, because the movement, if you allow movement and the sternum doesn't heal properly, it's a real problem in the longer term, because it won't heal in the long term if you don't let it heal in those first 6 to 12 weeks. But yes, early on, straight after surgery, it's not unusual to get a little bit of clicking. There's more than just the bony sternum. There is some cartilage, which then connects onto the bony ribs, and a lot of that bony musculoskeletal architecture is a bit disrupted, because they put the clamp in your chest and open up the chest, and so everything's not quite where it was when we started off, and so you'll get a bit of clicking and a bit of pain in those early stages after bypass surgery.
It's the alternative, though, I suppose, of an early death. So now, thinking about activity and returning to daily life, after having coronary artery bypass grafting, or a CABG, as I've now learned the acronym is, when is it safe to take a shower?
Taking a shower will happen in the first 48 hours probably.
So you don't have to worry about heat or steam or?
No, because they usually seal the wound with a dressing, and that dressing will stay on for a week or so, and whilst the skin actually heals and seals itself off, and that's done to protect against infection and other things, bleeding and infection particularly. So getting up and having a shower is not a problem, apart from the movements and the general discomfort of being in the surgical or post-surgical situation.
There's an interesting dichotomy of perspectives that are being shared online. So some people are talking about, my family's worried about me returning to usual activities. How can I reassure my family that I'm doing okay? And some people going, my family's pushing me to get back to regular activities, but I don't feel like I'm prepared. I'm worried I might have another heart attack. What should I do? So what do you think? What advice would you offer to someone who is perhaps worried about returning to their usual activities?
Well, this is why we have cardiac rehabilitation. In fact, cardiac rehabilitation was specifically designed in the first instance for patients who'd had bypass surgery. So the general recommendation is that you'll need 2 weeks of fairly low level activities, and after 2 weeks gradually increasing activities, so that by 4 weeks you're able to do some walking and perhaps extending those walks, and by 6 weeks you should be back to fairly normal activities in terms of walking and things. The limitation there is protecting the sternum, and we just advise against any lifting more than a couple of kilograms for 12 weeks after surgery. So the answer to the question is, the patient should have received some advice, some individualised advice at the time of discharge about returning to activities. And we specifically recommend cardiac rehabilitation because during the cardiac rehab process, we're able to impart that information about what's reasonable and sensible in terms of returning to normal activities. In a face-to-face cardiac rehabilitation situation, you often have some exercise component to the rehab process, which is designed to give people confidence that they can exert themselves without difficulties. The other issue is, of course, is to talk to your specialist on your follow-up appointments if you have concerns about returning to activities. And it's often wise to have a family member, spouse, or close family member who can attend with you or can participate in cardiac rehab as well.
And now you did mention activity or exercise as part of cardiac rehab. How might someone know if they've exercised too hard? They might be concerned that they're going to trigger another heart attack by how hard their heart is beating.
Well, we generally recommend patients limit their heart rate response to exercise, usually to 100, no more than 120 beats a minute as they're getting back to normal activities. It depends a little bit on what medication you're on. So if you're on a beta blocker, such as metoprolol or atenolol, then clearly your heart rate's not going to increase during exercise. And the recommendation around heart rate increase would be lower from that point of view. But yeah, just listening to the body itself. If you're short of breath or feeling too fatigued, or there's any dizziness or so on, then that's a time to pull back.
Mm-hmm. And what sort of activities might someone do during cardiac rehab? Like, what is recommended?
Well, there's probably better people to answer that question than me, particularly the physios and the cardiac rehab nurses who do the face-to-face rehab. But walking, light, what we call isometric exercise, so very light, weights and things like that. Sort of low-level activities which are going to require you to increase the heart rate a bit and to increase your breathing to try and improve the cardiac fitness or the level of cardiac fitness. Mm-hmm.
So you wouldn't say it's true that you have to exercise a lot if you want to have a healthy heart?
Not in the recovery phase, no. It's a matter of being sensible, allowing the body, but the healing process after bypass surgery, for example, will take at least 3 months. Mm-hmm. If you're older, it might take longer. If you're younger, it might take a little less. After that period, then clearly more exercise is better. And, but it depends on the individual and also what other medical problems you might have. A lot of older patients have arthritis. They might have had a joint replacement. They may have problems with circulation. They may have diabetes and have lack of sensation in their feet and a few other things which can impair ability to exercise. And therefore, then it's a matter of tailoring activities and things to the patient's abilities. And that's, again, where the cardiac rehab can be very useful.
Mm-hmm. I think there must be a lot of myths around recovery after a heart event. And I found quite a few questions around diet that came up online. Is it true that dark chocolate and red wine is good for your heart?
Difficult question. 70% cocoa chocolate is meant to have some antioxidant properties. So it's probably better than the lesser levels of cocoa, which
chocolate.
is more saturated fat, which is what we're concerned about, and also the calorie level. I mean, there's a lot of calories in chocolate, and sometimes what we're trying to achieve, depending on the patient's situation, is avoiding weight gain after bypass surgery. So that needs to be careful. So I don't think there's any specific rule about it. Red wine, well, all alcohol may have some slight benefits, but it's not a recommendation. Mm-hmm. And I don't think it really matters what the alcohol is in smaller quantities, of course, and perhaps not very frequently in the recovery phase. I mean, alcohol is a toxin to the heart muscle. It can certainly in larger quantities stimulate arrhythmias and certainly can raise blood pressure in the longer term. So it's certainly advisable to keep the alcohol intake to a relatively minimum level. It's not
quite the guilty pleasure you can get away with.
Yeah. Mm-hmm.
And another question that came up was around medication for cholesterol. So a question from a patient: I've struggled to change my diet, but since I've been taking cholesterol lowering drugs, can't I eat whatever I like now?
Well, if you've had a heart attack or and ended up having a stent or a bypass operation, you're going to end up almost certainly on cholesterol lowering medication. However, cholesterol medication works best when it's combined with a sensible low saturated fat diet, and we're aiming for the lowest levels of total cholesterol, and particularly LDL cholesterol, which is the bad cholesterol, that we can achieve without getting side effects from the medication. So the best way to do that is to combine a reasonable, sensible, low cholesterol diet or low saturated fat diet with the medication will achieve the best results. So it's a little counterproductive to have a diet which is not particularly heart safe, if you like, or heart recommended, if you're taking statin medication or other forms of cholesterol lowering medication.
And other people who might be looking for a shortcut towards a healthy diet, is there anything you can say about vitamins to prevent heart disease? Are there any?
No, not particularly. I mean, it's, again, a balanced diet will generally provide everything that you need. There may be some particular circumstances. So iron deficiency, sometimes we find, and there are occasionally people who develop B12 deficiency for gastrointestinal reasons. But there are medical conditions which kind of need medical diagnosis, if you like. In terms of the general sort of vitamins, the multivitamins and things like zinc and all the other things, I mean, they are essential, but a reasonably sensible diet with the 5 food groups would provide that without too much difficulty.
Fantastic. It's been very comprehensive so far. I do want to give people an opportunity. Did anyone have any questions around the activity or diet, since we're sort of on that topic right now?
Can I ask a question? Is a plant-based diet of much benefit?
You're talking a vegan diet or a vegetarian diet?
Probably, well, either of them, yes.
Mm-hmm.
Has there been anything to show that there is benefit? Yeah.
Not sure that there's anything to show there's been benefit. There's certainly no detriment if it's done properly. A vegan diet does need to be carefully judged because of some essential amino acids, which aren't particularly common in plant foods, but they can be found in certain plant foods. So there's certainly no problem with a plant-based diet, but it needs to be reasonably carefully thought out so that you are getting all of the essential amino acids and vitamins and minerals, basically. A vegan diet or plant-based diet does certainly help in terms of lowering saturated fats, and that's useful. As to whether that's better than a sensible non-plant-based diet, or at least omnivorous diet, if you like, I don't know that there's any particular information around that.
Thanks.
Yeah. Any other questions before we move on? That's right, we're going to come back. So I have some questions now around medications, and a lot of people who have had a heart event are on medications, and they can come with their benefits and side effects. One question was, since I started taking my heart medications, my interest in sex is pretty much non-existent and my husband is starting to complain. Is there anything I can do about it?
Well, certainly there are certain, I suppose that some of the medications can make people feel or lower their libido, but there may be many reasons for that. Being unwell alone will do that, age itself, and being deconditioned after a procedure or an event. Anxiety and depression are very common after a cardiac event. And they can certainly contribute to loss of libido and sexual function. So it's certainly worth discussing with your heart specialist or your GP. They hopefully would explore the possibility of signs of anxiety and depression and looking for other things that may be contributing. So maybe after bypass surgery, or even sometimes after a heart attack and a stent procedure, people are a little bit anemic, so their blood levels are a little low. And as I mentioned before, iron deficiency can play into that as well, and that can make people fatigued. So there's a number of things that should be looked at in that sense. And so certainly it's worth exploring that possibility if it's causing problems. Mm-hmm.
So don't just leap to assume that it's the medication. It could be a combination of factors.
Oh, absolutely. Mm-hmm. For men in particular, metoprolol and beta blockers and calcium channel blockers are well known to cause erectile dysfunction. So that can be a major issue. So that also needs to be thought about. Sometimes it's important to continue that medication. Other times we can find alternatives.
Mm. So it is worth having that conversation if it's something people are concerned about.
Absolutely. Again, in cardiac rehab, we generally would talk about that. And that's an opportunity for people to explore or raise some issues that they're having in that sort of supportive environment, and then if necessary seek further advice from the specialist or the GP.
Another question, and this has been quite a recent topic that's come up in some of the online forums I was checking out. I'm a heavy smoker with a heart condition, and I know I need to cut back, but the usual medications to help you quit smoking aren't working for me. A friend suggested vaping as an alternative to smoking, and I tried it and it seems to be working. But do you think I'm on the right track?
I think the advice, particularly the advice that's come out of the US and stuff most recently, is that vaping is not safe. And it's not a safe alternative to smoking. And we would not encourage that. There are alternatives in terms of nicotine replacement and other medications such as Champix and Zyban, which can help people with the cravings. Of course, if people have been smoking heavily for many years, it's extremely tough. And getting through that period of withdrawal is incredibly tough. It needs a lot of support. There's various supports available through the Quit line and through your local GP, and they have specific programs around supporting people to give up smoking. It is incredibly important. Smoking is a terribly damaging activity for the cardiovascular system. And if someone's had a heart event, we'd be just extremely hopeful that the patient would have the motivation and the support to be able to come off of the cigarettes, basically.
And how about medication and driving? I think my heart medication might be affecting my driving. What should I do about it?
Well, I think if anyone thinks something's affecting their driving, they shouldn't be driving for a start. That's pretty clear. Because if you're worried about it, there's going to be a lot of people on the road that are probably more worried about it, and probably your family as well. So most of the problems we have is people not being aware or denying that there's a problem. We have a lot more problems in that regard. But yes, there are not too many medications that would affect driving. I mean, again, beta blockers can affect your vision slightly, can cause slight blurriness of vision. I'm trying to think of what other ones might. I mean, anything that causes unusually low blood pressure, so dizziness, and other things that can contribute to low blood pressure, such as atrial fibrillation and arrhythmia. So if you're not feeling well, if you're not feeling well enough to drive, you should be looking at getting some assessment of what's going on, because that's not a usual situation. Most people can return to driving 2 weeks after a stent procedure, and 2 to 4 weeks after a bypass surgery, for a private vehicle, that is, heavy vehicle license.
Yeah, don't drive buses.
Well, there's a lot of people that I look after in the country who have heavy vehicle licenses, and generally they can't drive a heavy vehicle for 3 months.
And one last one for medications. I was told that green leafy vegetables might interfere with warfarin medication. Can I continue eating green leafy vegetables while taking warfarin?
Yes, you can. I mean, the warfarin is the vitamin K antagonist, and some green leafy vegetables, green leafy vegetables contain relatively high levels of vitamin K. But if you're on a relatively stable, reasonable dose of warfarin, then if you're doing something fairly regularly, so if you're eating green leafy vegetables 3 times a week, or you just continue doing that, and the stable dose that you've achieved with the warfarin should be quite adequate in that situation. There are situations where it can be a bit of an issue. I suppose the people that we're using warfarin for these days are predominantly people who have kidney function problems, or they have mechanical valves. A lot of patients these days who require anticoagulation, particularly for atrial fibrillation and other heart-related issues, are on the medications that don't require or are not interfered with by dietary measures or dietary content. But warfarin, yes, there are a number of things that can interfere with the vitamin K antagonism.
So good to be aware of it, but you don't necessarily have to rush out and completely change a perfectly good diet.
Well, that's the reason we have the monitoring of the INR. So when people are on warfarin, particularly in the early phases, they'll be having a blood test every week, and then every fortnight, and then once a month. And sometimes if they're really stable, they'll go out to every 6 weeks. And the idea of that is to pick up any particular problems or changes over time, which have led to a change in the metabolism of the warfarin, which is affecting their coagulation status, if you like.
Now, I just open it up to the audience again. Did anyone have any questions about medications specifically? Joe, did you have a question? No, that's all right. That was just a noise. Alini?
Oh, hi, Dr. Phil. Are you having questions from your patients about COVID vaccination and a potential influence on the heart health?
Almost every consultation, yes. And we're recommending that patients do have their COVID vaccination. And you can go by the current recommendations. So AstraZeneca, if you're over the age of 60, if you're under the age of 60, hopefully being able to access Pfizer. Even under the age of 60, the risks are very, very small. And, you know, there's some argument that you're better off having AstraZeneca vaccine now rather than waiting several months to get a Pfizer vaccine. Although the levels, even with the current lockdown in South Australia, the levels of community transmission are extremely low. So we're not too bad at the moment in that sense. There's no huge panic, although obviously we'd like to have as many people vaccinated as quickly as possible. As for the flu vaccination, again, that's recommended, and there's no contraindication to that. Not from the cardiac point of view.
Yeah, and Carolyn, did you have a question?
Oh, yes. Hi, Phil. It's Carolyn Astley here. Thanks for a great talk tonight. But I've got my husband sitting here who had a heart attack a couple of years ago, and he wants to know whether he has to be on his medications for the rest of his life.
Yeah, good question. Yes, I mean, I think, as you're probably aware, what we're trying to do is reduce the risks of a second event as much as possible. And the things that will do that are antiplatelet medication. So at least single antiplatelet medication, such as aspirin, is recommended for the long term. Cholesterol lowering medication to achieve what we call the target levels of cholesterol. So preferably total cholesterol below 4, and in fact, as far below 4 as we can get it without causing problems. And the LDL level, the bad cholesterol, below 1.8 or 1.8 or below. And to achieve those levels, most people do require ongoing medication. As people get older, blood pressure becomes more and more of an issue, and that's certainly something we like to control. And obviously we'd like to maintain blood pressure certainly less than 140 on 90 and probably less than 130 on 80. And again, as we get older, all of our blood pressures increase, and to be able to maintain those sort of target levels generally requires people to be on medication. A combination of those sort of medications has an enormous benefit in terms of secondary prevention, probably in the order of 50 to 70% reduction of risk when we use a combination of tablets. And of course, we want people to be on the lowest amount of tablets that they can be on to achieve those target levels. And we want people to be having medication that doesn't cause side effects. But yes, long-term medication is the aim to reduce risks as low as possible.
Excellent. Any other questions about medication, or shall we continue on to cardiac rehabilitation, which has been mentioned several times already so far? Oh, good. Let me leap into it. So I'm currently participating in a face-to-face cardiac rehab program, but I'm concerned about COVID, and I'm concerned about attending my group sessions and potentially being exposed. Should I continue or drop my sessions?
If we're going to talk specifically South Australia, again, once we get through this current lockdown, and presuming we go back to lower levels of restrictions, I think that the risk is extremely small. However, if there are some people who are particularly or feel particularly vulnerable because of their age or comorbidities, then it would be reasonable not to attend or to be out, as you know, in any potential exposure sites. Mind you, if you were attending a face-to-face rehab program in a hospital, it's quite likely you're going to be asked a number of questions, or everyone's going to be asked a number of questions to make sure that we've got a safe cohort of patients. Of course, in the country, we have access to the telephone-based cardiac rehabilitation. And I think if someone was unable or uncomfortable with attending a face-to-face cardiac rehab program, we would certainly look at enrolling them in the telephone-based cardiac rehabilitation, which is the same content, but delivered in a different manner. Same multidisciplinary teams involved, and that's certainly an alternative. Unfortunately, telephone-based cardiac rehab is not routinely available in the metropolitan areas at the moment. We're obviously working on that because there's a lot of people who can't attend face-to-face cardiac rehab, and the availability of telephone-based rehab is extremely helpful in our current lifestyle and community.
Yes, I dare say the tele-rehabilitation clinicians have been very busy over the last year and this year.
Yeah.
At what age would you say, at an older age, could you, I'll ask the question exactly how it was written. At my age, I don't see how cardiac rehab could help. Isn't it really too late for me?
Very unlikely, depending exactly on the age. Now, obviously, if you're not particularly active and you're 85 years old, there may be some limits to what we want to achieve there. It really depends on what the patient's potential is. If the patient has the potential to be leading a very normal, independent life and active life and doing normal activities, then I think there's a benefit to the whole idea of cardiac rehab is to get people back to that level of function as quickly as possible and as confidently as possible. So clearly there are a number of people at advanced years of age or with multiple comorbidities or physical limitations in whom cardiac rehab may not be that helpful, but that would be a very small minority of the people that we deal with.
And now maybe thinking about younger people, but people who still feel not ready. So I'm not sure about participating in cardiac rehab because I still feel too sick and that my body isn't ready. Can I or should I delay starting cardiac rehab for a while?
Well, certainly you can until you feel ready. There's no doubt about that. And if you're contacted by the cardiac rehabilitation staff, particularly as it's talking face-to-face cardiac rehab, then you can negotiate, a starting point for that. Generally, we start around about the 6 weeks post-event stage anyway. So most people should have recovered fairly well by that stage, even after bypass surgery, well enough to participate. Obviously, there'll be some people who have other medical issues and things which might impede that process. For people receiving the telephone-based cardiac rehab, really the only limitations there would be, significant hearing impairments or memory problems, dementia, and that sort of thing. And so, again, negotiation around the timing of that and the content of the rehab might be worthwhile in that situation.
Mm-hmm. But would you encourage people to investigate their opportunities before ruling it out?
Oh, absolutely. Yeah, I think at least talking to the cardiac rehab provider who's contacting you, asking any questions about what's involved and getting a clearer idea rather than relying on any fixed preconceptions about cardiac rehab, particularly where we have a number of options in terms of, certainly in the country, with the availability of telephone-based cardiac rehab versus face-to-face cardiac rehab. And it's worth mentioning that one of the large precepts around the CHAP program, which is the large research study we're running at the moment, is to try and expand the channels available to people to be able to receive that cardiac rehab content. We're also experimenting even with the cardiac telephone-based rehab of using video and YouTube type content to be able to assist people with the exercise-based component of cardiac rehab. So there's a number of things there that are designed to make cardiac rehab sensible, useful and value-adding to pretty much every patient, bar a small percentage of people.
So it sounds like someone will speak to you about cardiac rehab if you're in a position to take it. But if nobody does, should I ask for a referral if nobody mentions cardiac rehab?
Absolutely. Yeah. So everyone leaving hospital should be receiving My Heart, My Life from the Heart Foundation. That has strong recommendations around cardiac rehab. And you should, in fact, be receiving what we call phase 1 cardiac rehab in the hospital. So you should be able to talk to a cardiac rehab nurse or an informed nurse at the time of your admission or during your admission, so that at the time of discharge, it's fairly clear as to your options in terms of cardiac rehab. If you've left hospital, and this does happen, and people haven't been offered cardiac rehab, certainly getting back in contact with the hospital and saying, well, look, I really would like to do cardiac rehab. Can you please give me the contact numbers that I need for that? Or contacting our office through ICCNet to obtain those contact numbers. We would have the contact numbers for every cardiac rehab provider in South Australia. So that's quite a useful resource if people don't know where to go.
And one more question for this section. Can I accurately predict my risk of having another cardiac problem in the future?
Yeah, that's a difficult one, because essentially anyone who's had a cardiac event, so a heart attack or a stent or bypass surgery, we automatically would classify that patient as relatively high risk in terms of the population. That means you've probably got a 15 to 20% risk or more of having another event in the next 5 to 10 years, okay? So accurately predicting whether it's 18% or 28% is difficult. And the main objective is to try and lower that risk as much as possible by using the appropriate medications that we've talked about previously, because they do work, and good adherence to secondary prevention medication is critically important. I mean, I've been doing this job for 25 years, and it's quite clear to me that the people who are able to participate in secondary prevention, to take their situation seriously, to continue taking their medication and seeking regular follow-up in terms of their cholesterol levels, their blood pressures, their blood sugars, their general well-being, patients generally do extremely well.
Now, I'll open it back up to the group again, because I just have 2 more questions that don't fit into any category. So I've just lumped them at the end. Did anyone have any questions perhaps about cardiac rehabilitation? No worries, I'll continue. Just feel free to put up your hand if you do have any questions. So I had never heard of this until I found some information online about cough CPR, which apparently is the idea that you can help yourself by coughing vigorously if you think you're having a heart attack and you're alone. Have you ever heard of that? Is that really true?
That's in a basically a cardiac arrest situation where the heart is stopped, but unfortunately you probably won't know that the heart is stopped to be able to do that. There is a thing called precordial thump. So if we attend a patient who's collapsed, sometimes we'll administer a precordial thump, so a vigorous, a thump on over the heart has been known sometimes to work. I don't think it's particularly effective, but those things have some validity, but little practical application, I'd have to say.
Yeah, I wonder if you could cough vigorously, perhaps you could use that time to call 000.
Correct. By the time that's going to help, yes, it's in a practical sense, it's not going to help particularly.
It's interesting how these come online though, because I think there's a tiny grain of truth in there that
there is.
And I did have one last question, just because I have a particular interest in frailty, and so I tacked this on at the end. But given our aging population, do you have any advice on approaches for recognising and evaluating frailty during cardiac rehabilitation?
Yeah, I think it's a really good question. I think we're becoming more and more aware of the impact of frailty on people's outcomes. And I think this is largely through the work of the geriatricians, and we have teams now in the hospitals whose specific job is to look after the very elderly, those generally over the age of 80 with medical problems. And they've developed, pretty sophisticated ways of measuring frailty. We know that patients' frailty scores impact upon their ability to, or their risk of surgery and other procedures. As for measuring frailty in cardiac rehab, I don't know that we use any specific tools in that regard, and maybe we should. And it comes back to that question of are there people who aren't really suitable for cardiac rehab because of various impeding factors on their ability to move or their general health. So I think it has some relevance, but I don't know that we've got any specific tools that we use at the moment in that regard.
Yeah, I don't think it's quite, there's some tools that can be used, which I think have crossover, but maybe it hasn't been implemented. That's something to consider for future rehab programs. So we do have a little bit of time left. I'll open it up to the group again. So if you do have a question, please feel free to put up your hand. But can you summarize, what advice would you give to someone who is staring down the barrel at a open heart surgery or has a loved one who had a heart attack? What is their life going to look like post heart attack or heart event?
Yeah. So when we talk about a heart event, there are people who might have open heart surgery for reasons other than having had a heart attack. So there's quite a large number of patients who have valvular heart disease who require open heart surgery. And their recovery is very similar to patients who've had open heart surgery because of a heart attack or angina, because the procedure is pretty much the same in your open heart surgery. However, the long-term outcomes might be somewhat more favourable in that situation, because you're not dealing with atherosclerosis, the hardening of the arteries process, which tends to be progressive. But having said that, with our secondary prevention measures, we're designed to try and prevent that progression of the atherosclerosis or the hardening of the arteries. So generally speaking, our aim is get people back. The whole aim of cardiac rehabilitation is get people back to their former level of function. And one of the other specific aims is to get people back to work if they are of working age. So generally the aim is to get people back to their former good level of function, and often better than they were before, because they don't have the limitations from angina or shortness of breath from a leaking or narrowed valve. So I think generally people can be quite positive about the long term. As I said, the process of recovery can be anything from a few days and weeks to 12 months, depending on age and what was done. But in the long term, beyond that period of recovery and rehabilitation, we'd be very much hoping that people are back to normal function.
And then if people were interested in finding more information about improving their heart health, where would you direct them?
Heart Foundation. Simple.
Yeah, and they create the My Heart, My Life book, so they know what they're talking about. Yeah. And
their website is extremely helpful. They also have a helpline, which you can contact and ask for advice. Their website has enormous amounts of useful information around diet, exercise, anything related to cardiac disease, basically. So it is an absolute mine of information, which is extremely useful, extremely well curated in terms of the quality. It's usually curated by multiple experts It's very well balanced, and you can forget the rest of the web, and you can go to the Heart Foundation website, and that's all you need to know.
They've got some fantastic recipes. And I did look at their walking groups. You can join walking groups now. So
Yeah,
it can be a very, very social affair.
That's right.
So is there anything else that you want to share with us today before we close out the session?
Just to be one final message where people have had a previous event. One of the things we found is that when we did some research quite some years ago, is that people who had an event took longer to come to hospital the second time than they did the first time. And we don't really know why that is. And certainly any signs of recurrent problem after a cardiac event, so recurrence of chest pain, unusual shortness of breath, feeling irregularity of the heart rate or palpitations, unusual dizziness or swelling of the ankles, particularly chest pain and shortness of breath, should always be taken seriously. There's always places available 24/7, and particularly calling an ambulance and getting to a place where we can assess you properly. It's often hard enough for us as the clinicians to be able to immediately diagnose what's going on, but with our tools and our expertise, we are able to do that. Usually now within 12 hours, we can come to a diagnosis. If it turns out not to be a cardiac problem, well and good. We can get you home again and you can get on with life. But if you miss the opportunity to come and see us at an early stage with those symptoms, often the outcomes aren't good. So
fantastic advice.
Yeah.
Well, thank you so much, Phil. This has been super informative, and I think it's going to be a great resource. So I'm glad that we've got this on the record. So I'll draw the session to a close there, and we will follow up with a second session later on this year for people who might be interested in hearing from our CHAP pharmacologist. And thank you so much, everyone, for joining us here tonight and for your interesting questions. If you do have any questions coming out of this session, please feel free to contact me. My email address is on the original marketing for this session, and you can always check out the CHAP project webpage at chapproject.com, I believe it is. Yeah. So yeah, thank you very much, Phil, and we'll let you go back to your probably extremely busy life right now with the COVID situation, but we really appreciate you taking the time to talk to us tonight.
More than a pleasure. Thank you.
Fantastic. Thank you very much, guys. Good night to everyone, and yeah, stay healthy and safe in our current COVID situation. Thanks very much, guys.
Bye.
Bye.
Thank you. Bye.
Thanks.